today. I am Yoshio Haga, the Director of Clinical Research Institute. And today we are very happy to invite Professor Jeffrey Hagen from Los Angeles, California. And you know Professor Hagen is Chief of Esophageal Cancer Surgery in USC. USC is one of the largest high-volume centers for esophageal cancer surgery. Probably number one throughout the world. So there are three big centers. One is Johns Hopkins University Hospital and USC, and Munich Technology University Hospital. These are the three major high-volume centers for esophageal cancer. And he is the chief of this part. And USC is also very famous for emergency room. It is the largest emergency room in the United States of America. So today we want him to talk about acute care surgery. It is a new field of surgical specialty. There are the specialized team for the emergency operations. So it will be very fun. Could you start the lecture, please?
Is it working? Okay. Thank you, Dr. Haga, for the kind introduction and for inviting me back again to Kumamoto. It's really a highlight of my year to spend some time with you all here. We're going to talk this evening about the field of acute care surgery, which is, as Dr. Haga mentioned, a specialty that has emerged in the United States for dealing with both trauma and non-trauma emergency surgery. As I said, it's a great pleasure to be back here. It's great memories of all the fun people and fun times and sightseeing and things, and I look forward to the rest of the week as well. I've listed here my contact information. The email is pretty easy to remember. It's just my name at usc.edu. And if any of you have the opportunity to come to the United States, and particularly Los Angeles, please let me know so that we can get together. Oops. So before I talk about acute care surgery in the United States, I just want to give a little bit of background about our medical center for those of you who I've not spoken to before, tell you a little bit about our medical center. It has a long history in American medicine. It was first formed in 1878 as a very small 100-bed hospital. About 2 years later, the University of Southern California was founded by the Methodist Church, and it was the first major research university in the Western United States. The two of these, the County Hospital and USC, joined together to form the Los Angeles College of Medicine in 1885, which was actually 8 years before Johns Hopkins Medical School came into existence. At the time, there were no faculty in the clinical sciences, and the hospital was staffed by community physicians, and they've hired their first interns to work there in 1887. So a very long history of training residents at USC. The hospital that most people are familiar with is this one, which is the county facility that was opened in 1933. When it was built, it was the largest teaching hospital in the United States, almost 1,400 beds. After World War II, it increased to more than 3,500 beds, making it by far the largest hospital in the United States. In 1919, the College of Medicine closed for financial reasons, and it was about 10 years later that USC opened their own School of Medicine in 1928, so almost 100 years ago. They brought Charles Rowan from Iowa State to be the first chairman, but again, he didn't have any faculty. It was just private surgeons that were working at the county at the time. The first full-time faculty were hired in 1940, but that only lasted for a couple of years until World War II came about, and most of the surgeons were drafted into military service. And so after the war in 1952, the USC School of Medicine again opened up practice at the county hospital with Leonard Rosoff as the first chairman. In 1994, there was a rather large earthquake, a 6.4 earthquake in Northridge, California, that caused damage to that county facility, and it was no longer available or no longer suitable for patient care purposes, and so they began the construction of this new hospital just down the hill from the big county hospital. And the cost of construction was $1.4 billion, making it the most expensive hospital built in California. And it was opened in September of 2008. It's a giant structure, more than 160,000 square meters, and it's 3 city blocks long. It has 3 parts. This is the outpatient clinic center, which is about 3,500 square feet, and that's where all of the clinical activity at the county hospital occurs, and we treat more than 1 million patient visits per year in this clinic facility. In the center of the 3 buildings is the Diagnostic and Treatment Tower, which is about 45,000 square feet, 5 stories tall, and that's where all of the essential patient care services, the operating room, the radiology, and the emergency medicine department are located. And then down at the far end is the patient tower, which is an 8-story structure, about 65,000 square meters, which includes 650 hospital beds, 180 of them ICU beds, and the rest a mix of medical surgical beds at the county hospital. When it was built, it was the most modern hospital in California. It has state-of-the-art, 32 state-of-the-art, fully equipped minimally invasive surgery suites. One of them you see over here. 5 of them have teleconferencing facilities, and we have a hybrid operating room for vascular and cardiac procedures. It's the home to 714 full-time faculty that teach at USC, and we train almost 900 interns and residents in the training programs there, and more than 40,000 annual hospital admissions. The other parts of our academic medical center include the Norris Cancer Center, which is, this building here. It is a 60-bed hospital that's dedicated to the care of cancer patients, and it includes all of the outpatient facilities for medical oncology, including an infusion center. And then the last piece of our academic medical center is what's called the Keck Hospital of USC, shown here, and that's the private hospital that was built in 1991. There's 265 beds. And this provided an opportunity for the faculty at USC to develop a private practice to help support their academic efforts, which was really key in expanding. More than 700 new faculty were hired, 80 of them in the Department of Surgery after this new hospital opened. And then about 7 years ago, we added this tower to bring our capacity to 411 beds. So with that as a background, I'm going to talk this evening about acute care surgery in the context of the history of trauma surgery in America and some of the challenges that that specialty faces. And that has all led to the development of the acute care surgery model, which we're going to talk about, and then I'll focus specifically on how we're doing this at the LA County Medical Center. The history of trauma surgery in the United States can be traced back to this guy. His name is George Goodfellow, and he was credited as being the first trauma surgeon in the United States in 1880. He moved to Tombstone, Arizona during the silver boom there and opened an office or a practice as a general surgeon, and he practiced there for 11 years. He performed the first known laparotomy for a gunshot wound, which was on a miner who had been in a shootout, and he successfully repaired 6 wounds to the small and large intestine, and the miner, to most people's surprise, actually survived. He treated a number of very famous outlaws while he was in Arizona, including Wyatt Earp and Virgil Earp, at the gunfight at the OK Corral in 1881. And he was a real authority in the management of trauma, publishing 13 of the earliest articles on the management of gunshot wounds to the abdomen. But with the exception of the Wild West, most of trauma care in the United States was related to industrial accidents. Back around the turn of the century, almost a little over 3 million people were injured in industrial accidents every year, causing a great deal of disability and accounting for 25% of all accidental deaths in the United States. Most of these injuries were related to fractures. In this report from the railroad industry, which was responsible for a large percentage of these industrial accidents, they spent about half of their money on fixing injuries related to the treatment of fractures. And so this led the American College of Surgeons to create what was called the Committee on Fractures in 1922 to study how to better care for these patients and reduce the complications associated with fractures. And Charles Scudder, who is a very famous trauma surgeon in the early 1900s, was the first chairman. In 1939, this became the Committee on Fractures and Other Trauma, recognizing an increasing number of other traumatic injuries that were occurring, and that led to the formation of what we know today as the American College of Surgeons Committee on Trauma. The first organized society for this surgery of trauma was the American Association for Surgery of Trauma, which was founded in 1940. So around that same time, the concept of trauma hospitals, or what they called at the time accident hospitals, emerged. And the first of these was actually in Birmingham, England, where they opened a hospital called the Birmingham Accident Hospital. Actually at the time, the Queen's Hospital in Birmingham was scheduled to close. It was 100 years old, and they were moving into a new facility, and so they repurposed it to create this accident hospital. The first and only such accident hospital in the United States was opened in 1968. It was called the Maryland Institute for Emergency Medical Services, and it's now known as the Maryland Shock Trauma Institute, which began in 1968. But unlike this concept of trauma hospitals, which was popular in Europe, in the United States, this was the only accident hospital that was created, and the predominant model was for trauma services or programs to be developed at the large existing public or teaching hospitals. The first two of these were in Cook County in Chicago and at San Francisco General Hospital in California, where they established dedicated trauma services in 1966. So less than 50 years of history of organized trauma in the United States. trauma surgery in the United States. There was a rapid expansion at many of the major academic medical centers of the time to include trauma services, including our own LA County Hospital in the early 1970s. So when you look at the history of trauma, there are a number of significant influences that shape the specialty in addition to the Industrial Revolution and the injuries associated with that I mentioned. And a couple of those are the military experience during the 20th century and the emergence in the United States of civilian or gang violence, which led to a proliferation of penetrating injuries that we had to deal with. In terms of the impact of military experience on trauma surgery, this was actually recognized way back in the time of Hippocrates, who said, "He who wishes to be a surgeon should go to war," really emphasizing that a lot can be learned of a surgeon who wants to deal with the injured patient by working in that sort of environment. A number of substantial developments or events occurred through the military experience, including World War I, where blood transfusions were first used for trauma victims. And then we had Hagen, who provided us with a detailed description of the physiology of shock. Most of the principles we still use today. And it was at that time that x-rays were first introduced into the battlefield, significantly improving the management of fractures. World War II, probably the most important development, was the beginning of the use of antibiotics, penicillin, and sulfa drugs, which significantly improved the military surgeon's ability to operate and fix the injuries that they faced. There were also a number of other developments, including for the first time the use of helicopters to rapidly evacuate the wounded from the battlefield. In the Korean War, the MASH unit concept was developed to move surgery to the front lines, emphasizing the importance of the concept of the golden hour in surgery, of getting the patient to the operating room as quickly as possible. So they moved the hospitals to the front lines to accomplish this goal. And then there was a significant improvement in our understanding of the treatment of vascular injuries through the Korean conflict, as vascular repair became the preferred treatment over amputation. In the Vietnam War, blood transfusion and its benefits in the trauma victim was rapidly recognized, and from 65 to 69 you can see a dramatic increase in the amount of blood that was transfused to the victims, and there was a recognition of the need to employ specialists or deploy specialists to the field, especially in the areas of vascular and neurosurgery. All that was well and good until the next military conflict that the United States was involved with, and that was the first Gulf War. And they rapidly recognized that we had a paucity of qualified, experienced trauma surgeons that were available to treat the soldiers that were injured, and particularly there was a limited access to specialists. And the difference between the other wars and the first Gulf War and the Somalia conflict that followed it was that we had transitioned to a voluntary military in the United States. They could no longer draft and mandate all of these trauma surgeons and specialists into the military. And so the government established this program that was called the Military Trauma Training Program to help deal with this deficit. So USC was chosen by the Navy from 60 trauma centers that applied to be the trauma training program for the physicians in the Navy, and there's a similar facility in Miami for the United States Army. And what we do is get on a rotating schedule for about a month of experience, 2 teams of surgeons, anesthesiologists, OR nurses, technicians, and corpsmen who come and spend a month working with us in the trauma division to gain exposure and experience about 3 to 6 months before they're deployed. And to date, we've trained about 140 physicians, mostly surgeons, similar number of nurses, and about 240 corpsmen to prepare them for their battlefield experience. So with the development of these focused trauma programs at the major medical centers around the United States, we entered what has been called the golden age of trauma surgery in the 1980s. At that time, general surgery residencies were highly competitive in the United States, and many of the best and the brightest graduates of these programs went into trauma. It was a glamorous life. The surgeons would swoop in and whisk these desperately ill patients to the operating room to save their lives. And trauma really gathered significant political clout both in surgery and with the government, and a lot of dramatic changes occurred in the processes of trauma care, including creation of designated trauma centers and reforms in our emergency medical services systems. At the same time, there was inconsistency and chaos, really, in the emergency departments in the United States. Most of them were staffed by internal medicine physicians and family practice physicians who couldn't make it in private practice, and people who had dropped out of surgical residency programs. And that was the only job they could get, and there was plenty of them available. So surgeons really took charge. They declared that trauma was a surgical disease based on this concept of the golden hour and the emphasis on importance of rapidly getting these patients to the operating room. The guidelines for the American College of Surgeons at the time stated that the surgeon serves as the captain of the team and is expected to be in the operating room when the patient arrives. So everything went along great until the early part of the 20th century, when you started to get a lot of concern. There's a bunch of people here who are well known in the field of trauma in the United States who started to express concern about the future of trauma as a specialty. Dr. Kreiner said the specialty of trauma is in trouble. Dr. Esposito said it's in the throes of an identity crisis that threatens its future. The status quo is no longer tenable, and trauma as a specialty is gasping for air. So what is it that created this crisis in trauma surgery in the United States? Well, there's a number of factors, and we're going to talk briefly about each of these, because these are the factors that have led to the development of acute care surgery as a specialty. So first, there's the declining interest of surgery in surgery as a specialty. During this time, the so-called golden era of trauma surgery, you can see that about 12% of all graduates of medical schools in the United States wanted to go into surgery. But then you'll notice about 1990, those numbers started to decline. And at the same time, emergency medicine was just emerging as a specialty, rapidly proliferated to the point where in about 1997, the number of physicians that graduate from emergency medicine programs exceeded the number of surgeons that were being trained. Not only was there a decline in interest in surgery, but there was a decline in interest in trauma surgery as well. In 2012, only 40% of the available training programs in trauma and critical care in the United States were filling through the match. And it's estimated that by 2014, all across the United States, there will be a shortage of about 1,500 qualified trauma surgeons to provide the needed trauma care. And the reasons for these changes are lifestyle considerations, a lower rate of job satisfaction, and decreased reimbursement that we're going to talk about a little bit. The competition for all of these best and brightest surgeons has been specialization. Over the past decade, there's been a dramatic rise in the number of general surgery residents who graduate from their programs that go on to specialty or fellowship training. And now, more than 3/4 of the residents who graduate go on for further training. And the reasons for this are competition for the best jobs, but also the increasing complexity of surgery. And it's really become a situation where if you're not specialized or focused in something, it's difficult to find a quality job. So as a result of this, general surgeons are on the decline. They amount to only 4% of all physicians in the United States, which is a decrease of 50% over the past decade. But one of the biggest factors that's contributing to the decline in trauma surgery's prominence has been the shift to non-operative management of trauma. In the golden era, all penetrating and most blunt injuries to the abdomen or chest were routinely explored. But we've had massive developments and rapid developments in the quality and speed of CT imaging, which really has replaced the need for all of these mandatory laparotomies. And so now the practice of trauma surgery has moved from this dramatic, glorified rushing the patients to the operating room to save their life to a situation where you're just following protocols and managing the patient on the wards. In fact, at most trauma centers, only about 3% of the patients who are evaluated by the trauma surgery team end up having an actual operation. So it's said that at level 1 trauma centers like ours, a trauma surgeon has to evaluate 10 patients, admit 9 of them, treat them for 65 days of inpatient care for every patient that they take to the operating room. So you have all of these surgeons, the best and the brightest of their group, who want to operate, and they're no longer operating. In addition, we had competition from emergency medicine, as I mentioned. It emerged as a specialty in 1979, about 60 years after surgery became its own specialty. And much of the development of emergency medicine as a specialty emerged out of USC. Dr. Gail Anderson came to LA County Medical Center in 1971 and established what he referred to as the Emergency Medicine Service. This was followed 5 years later by the founding of the American Board of Emergency Medicine, and then 3 years later they emerged as a certified specialty. This program has expanded dramatically over the years to the point where it now includes 25 full-time faculty, 99 part-time faculty, and 72 residents in emergency medicine that take care of more than 500 patient visits in the emergency room per day. As Dr. Hagen said, it's the largest emergency room in the United States. It's 9,000 square meters in size and has 109 beds. And in that area, we take care of more than 200,000 patient visits per year in this fully equipped modern emergency department. So what's happened now is we have all of these specialists well-trained in evaluating and resuscitating victims of trauma that specialize in emergency medicine, and so now, and then very few of the patients are actually being operated on. And so in the realm of treating trauma victims, surgeons were no longer the king. There's also a financial burden that discourages people from entering into this field. If you practice trauma surgery, that interferes with all of the conduct of elective surgical practice. It interferes with your clinic, it interferes with your elective operating schedule. And trauma victims represent a disproportionate number of the 45 million Americans who lack health insurance. In fact, it's been estimated that it costs almost $200,000 in income from patients who treat, or patients who work in the emergency department because of the burden of these uninsured. Emergency work also pays less than elective private surgery in the United States, and there's a higher risk of malpractice suits if you provide trauma and emergency surgery. These uninsured patients are more likely to sue. They have urgent emergent care, which is inherently more risky. Patients are older and sicker. And the hospitals are often not staffed well at night and weekends when most of this activity occurs. So in addition to all of these factors that are challenging the trauma surgeons themselves, hospitals are faced with a little bit of a different problem, and that is how to manage the care of the non-trauma emergency patients. Our emergency rooms are increasingly overcrowded. This is a particular problem in rural areas. And most of the common reasons why people come to the emergency department are for surgical illnesses. They have injuries, abdominal pain, and the like. But many surgeons in the United States are refusing to take call in the emergency room for lifestyle reasons, for the financial reasons that I mentioned before. And in fact, overall, there's a shortage of surgeons in the United States that's been estimated to be about 35,000 surgeons. We only graduate 1,000 per year in the United States, so it gives you an idea of how much of a shortage there is of surgeons to provide this type of care. And finally, hospitals are faced with financial strains because if you have an emergency department, you need to have an operating room available and staffed 24 hours a day, 7 days a week, which is quite costly, especially for small hospitals. In addition, hospitals are closing across the United States. In the decade from '93 to 2003, 79 hospitals closed in California alone, and 700 of them nationwide. Almost 200,000 beds were closed, and 425 emergency rooms shut down. It's estimated that 80% of all hospitals in California are currently losing money, so more hospitals are likely to close. And this problem, this burden of emergency surgery cases is only going to get worse, especially as our population ages and more of these patients will be coming in. In addition to those two forces, there's also a need for more surgical critical care specialists in the United States. Life expectancy is increasing, so we're getting older and sicker patients. We're doing more complex operations that require more or that have more potential complications, and ICU care itself is becoming increasingly specialized. And so as a consequence, there's a very real need for physicians that are trained in surgical critical care to deal with these patients. So the response to all of these factors, the need for surgical critical care specialists, the hospital's desire to have better coverage for emergency cases, and trauma surgeons' desire for a better life, the American College of Surgeons formed a committee called the Consideration of Trauma Specialization in 2002, and their goal was to focus on the problems of access to emergency surgery and the future viability of trauma surgery as a career. This became the committee to develop reorganized specialty of trauma, surgical critical care, and emergency surgery in 2003, which 2 years later was named the Acute Care Surgery Committee of the American College of Surgeons. After that, they drafted recommendations for how these fellowships should be organized, and the first fellowship in acute care surgery opened at the University of Nevada in 2007. Since that time, within about a year, there were 6 additional programs, as listed here, that opened acute care surgery training programs to begin the emergence of this as a new specialty in the United States. So this training program is a 2-year program that follows the completion of your general surgery residency, and it includes a dedicated experience for 6 months minimum in surgical critical care. And then the rest of the time you would spend on a variety of different rotations in various specialties. And the recommendations are about 6 months of acute care and trauma surgery, 1 to 3 months of thoracic, 1 to 3 months of transplant and hepatobiliary, 1 to 3 months of vascular, and then a month each on neurosurgery and orthopedics, and some burn experience as well. So the idea is that the graduates of these fellowship programs will have exposure and experience to really all types of patients who might come in with emergency situations through the Department of Emergency Medicine. And it seems that this type of a program does work. There are a number of publications that are coming out now over the past couple of years to document the feasibility of this approach. This was a review of 5-year experience at Vanderbilt in Tennessee, where the acute care surgery service was shown to decrease mortality, as you see here, over time, and also length of stay for patients who have non-trauma emergency procedures performed, and importantly, they found no negative impact on the results of their trauma. So you can add these additional components to the program without negatively impacting on trauma care. The types of procedures that are performed by a typical acute care surgery service are shown over here. It's all of the usual suspects and appendectomies, cholecystectomies, necrotizing fasciitis and abscesses, colectomies, all of the usual emergency types of procedures that might come in through the emergency room. And in this study, looking at their first year of experience in Eastern Virginia, they found that the patients were getting to the operating room more quickly, and that was helping to decrease the length of stay and complications. So what about at USC? Well, our experience at USC with trauma surgery really paralleled what was going on nationwide. Back in around the turn of the century, we were part of the Wild West. We had private practice surgeons that came and went and performed all different types of operations that might be required with really no formal training or experience. In the middle part of the century, we started to organize a little bit and get some full-time faculty in surgery, but they were on a rotating basis, just taking call, performing emergency procedures and elective operations at the same time. During the golden era of trauma, we, as I mentioned before, were one of the early programs to organize a formal trauma program in 1975, and that continued on until the early 1990s. But these were not dedicated trauma surgeons for the most part. In fact, in 1991, when I came to USC, I was on call every Thursday night and taking care of trauma. And that's just the way it worked. Everybody had to take their shift. So there was a bunch of surgeons that were working full-time, doing their private practice, and at the same time having this. And so all of the same issues that we were facing nationally, interfering with practice, quality of life issues, etc., we were facing at USC. So in 1991, we established a formal division of trauma surgery at USC. This is Dr. Dimitriadis, the head, who was recruited from Johannesburg, South Africa, to come head up the trauma program at USC. And so that replaced, that replaced all of us general surgeons who were on call with dedicated faculty with formal fellowship training in trauma surgery. And they organized 3 teams that took call every third night. And this led to a rapid growth in the division. There were 8 full-time trauma surgeons, nurse critical care specialists, and we, of course, had residents assigned to the program and established a trauma fellowship training program that was a 2-year program at the time it was established. At the same time, we established what was called the non-trauma emergency service, which was a service designed to take care of everything else that came through the emergency room besides trauma. This was a busy service. You can see we admitted 4 patients per day, saw 9 additional patients in the emergency room, and 22 other consults around the hospital for potential acute surgical conditions. We did 3 major operations per day and about 2.5 on average minor procedures per day on this non-trauma emergency service with all of the usual acute surgical emergencies, as you see here. This was an active service on the research side as well. A lot of outcomes research in hernias, gallbladders, antibiotic studies in abdominal sepsis, etc. So it was a pretty well-functioning service. But the problem is that we started to experience at USC the same problem that everyone else in trauma surgery was experiencing nationwide, and that is trauma surgery was becoming a non-operative specialty. And actually, USC was a significant part of this whole movement in surgery, and I'll show you a couple of the studies here. This was one of the first studies that looked at non-operative management of patients with penetrating injuries to the abdomen. The traditional approach, the traditional teaching was that if you had a penetrating injury to the abdomen, you had to go to the operating room for exploration, especially in the presence of a gunshot wound. But we found in this study of 309 patients that almost a third of the patients could be successfully managed without an operation if the patient was hemodynamically stable. And so for the first time, we started to rethink some of these practices that came out of the golden era of trauma. Another study from a year later looking at gunshot wounds to the back, and you can see the fragments of the bullet here as the patient was shot from the back here. And it was, again, all of these patients were routinely explored according to the principles of trauma surgery. But we found in this study that out of 203 patients, 2/3 of the patients never needed an operation when they were managed by CT imaging and selective non-operative management. With time, we expanded the indications for non-operative management to some pretty devastating looking injuries. Here's a gunshot wound to the liver that goes right through the middle of the liver, in and out. Here you see a spleen that's fractured from a stab wound. And here you see a kidney that's been lacerated. I can't remember if that was a gunshot or stab wound, but pretty significant injuries to solid organs that, again, 15, 20 years ago, these patients would have been immediately taken to the operating room for exploration. But we found that as many as a quarter of these patients can be successfully managed without operation. So that's good for the patients, but not so good for the trauma surgeons. And here's a couple of additional examples. Some pretty dramatic injuries. There's a bullet fragment here. Injuries to the liver that were all successfully managed without taking the patient to the operating room. The principle of non-operative management also moved into penetrating neck injuries. The classic recommendations for managing penetrating injuries to the neck are shown here. Zone 2, which goes from the ear to the clavicle basically, were routinely explored. For higher injuries and lower injuries, it was recommended that they have angiography and endoscopy prior to exploration, but really the practice was to explore essentially every penetrating wound to the neck. But looking at our experience, we found that many of these explorations were not therapeutic. In fact, in this series of 223 penetrating injuries to the neck, some of them shown here, half and half stab wounds and gun wounds, the gunshot wounds, only 17% of the gunshot wounds and only 10% of the stab wounds actually required anything therapeutic during the operation. And so the conclusion of this study was that you can non-operatively manage the majority of the penetrating injuries to the neck if a quality CT angio is done and doesn't show any significant injury. So all of this trend toward non-operative management had a significant impact on the experience with our trauma service. Here you see numbers from the early 2000s. The numbers of actual trauma cases has not really changed all that much over this decade from here to here. But what you notice is almost half of the patients were operated on back in 2001, and a decade later, it's down to about a quarter. So a substantial reduction in the number of patients that are being taken to the operating room. Again, this is good for the patients, but it's not a sustainable model for the surgeons that are involved. And if you look at the experience of these surgeons, there's 1,100 cases during the entire year. There's 8 faculty, so that's only 2.5 operations per week for the faculty members and less than 2 per week for the residents. So it's not very satisfying for these surgeons who like to operate, and it's not a good training experience for the residents. So because of these issues, we created the acute care surgery model at USC just a little over 4 years ago. And we created 4 acute care surgery services to replace the trauma and non-trauma emergency services. There's 4 residents on each team, 2 faculty that are available in-house 24 hours a day, 7 days a week, and they provide full-time coverage to the surgical critical care, which was the 3rd part of the acute care surgery model that I mentioned. They cover all trauma, all surgical critical care, and all non-trauma emergencies that come into the hospital. And immediately there was a dramatic increase in the amount of operations done by these surgeons and by these residents, almost a 4-fold increase in their operative experience. So now we had happy surgeons. They were in the operating room doing what they like to do. But the majority of these were non-trauma emergencies, so this trauma volume didn't go up. It's just the surgical experience was improved. So this is the size of the faculty in the acute care surgery, formerly trauma division. You can see it's much bigger. This picture was taken in 2002, and there's about 6 more that have been recruited as we've expanded the acute care surgery model from the county hospital over to the Keck Medical Center as well. This is a listing as of this week of the approved acute care surgery training programs in the United States. We don't have a formal training program at USC yet. We are training our fellows in the same fashion as an acute care surgery program. We've just not processed yet the formal application and site visit. But we have a 2-year trauma and critical care fellowship that satisfies all of the experience requirements of acute care surgery. So what is a typical day like on the acute care surgery service at County? It starts off at 7 a.m. when you get this whole group of people together for what's called pass-on rounds. The faculty members who are on call the day before and the faculty members who are on call that night gather together with the residents from both teams, some nurse practitioners and PAs and the medical students, and they all sit around a table together in the morning. They review all of the cases that were operated on the day before. They review the cases that are pending surgery for the following day. They discuss all of the consults so that we provide a safe handoff in this transition of care. This is a typical list of activity for a day on the acute care surgery service. You see they did 4 operations, a couple of trauma, a couple of non-trauma. They had 2 patients on the OR board waiting for surgery. And then you see this long list of other consults, a lot of motor vehicle accidents, a gunshot wound to the chest that was managed non-operatively, all of the sort of mix in the typical day of acute care surgery. After pass-on rounds, the part of the team goes off to do the emergency cases Monday through Friday to clean up the cases that are on the board. The rest of the people go to the ICU to do surgical critical care rounds. There's also a lot of conferences, core curriculum, skills lab that we'll talk about a little bit, outpatient clinic to round out the activities of the acute care surgery service. One of the most important things that the acute care surgery service has provided to us, besides good quality care, is an outstanding opportunity to train our residents. We have a large group of faculty on that service that are focused on educating our residents in all aspects of the management of surgical emergencies. Every Tuesday morning, they have a skills lab session that's focused on trauma, ICU, and other emergency procedures. We go through basic procedures like central line, chest tube suturing, etc. for the interns. We have a variety of simulators, and we have animal models of trauma that we use. One of the best simulators we have is this simulator that's called the MEDI Human Patient Simulator. It was developed by the Department of Defense to simulate an injured trauma, in this case battlefield injury. It has simulated vital signs. It can even bleed on command, and it really provides quality real-time feedback to the residents as they're training on the management of the trauma victim, and it's been a source of educational research as well. There's the MEDI simulator shown close up, dressed up in his fatigues, and we have a number of other simulators that we use for training our residents. In our skills lab, we also have an animal lab where we can do large animal, usually pig, training. So it provides our residents the opportunity to practice some of the procedures when appropriate in the animal model. And this is just a partial listing of all of the non-trauma procedures and the trauma modules that are conducted in the skills lab to provide our residents with the opportunity for hands-on training before they're taken to the operating room or the trauma bay. One of the most recent developments, and I think the most exciting in terms of training our residents in acute care surgery, is what's called the Fresh Tissue Dissection Lab. This is a very unique program that we have at USC. It came out of some negotiations between surgery, pathology, and the coroner's office. In Los Angeles, being a big city like it is, we have a lot of what's referred to as unclaimed dead. These are people that die and they don't have any next of kin that can be identified. And the normal process is after a period of searching for the next of kin, they are cremated and their remains are placed in a mass grave. We made arrangements with the coroner's office and the state of California, the State Board of the Unclaimed Dead, to have these fresh cadavers made available to us for education purposes. These are not like the cadavers you see in medical school. They're not embalmed. They're kept in the refrigerator and fresh. So they're extremely lifelike, and the things that we can do in terms of training our residents is unparalleled. We've even had our perfusionists from the cardiac service work with us to create a perfused model where simulated blood, red and blue, is put in the arteries and veins with pressurization from perfusion, so it really is a very lifelike experience for our residents to practice these procedures. It's relatively inexpensive, it's very realistic, and you can actually perform full operations on these cadavers, or on these fresh cadavers. And so you see, let me go back. You can see here tracheostomies, venous cut downs. You can see over here, this is an emergency room thoracotomy being practiced by our residents. You can see fasciotomies, venous cut downs, all of the types of emergency procedures that you might be asked to perform in the acute care surgery specialty or setting, and all of these can be done in the safe environment of the skills lab. We have had, as of 2006, which was 1 year after the program opened, I need to update this slide, but we do about 80 sessions with these fresh tissue dissection labs per year. It's really an enormous benefit for our residents. We spend a lot of time working on difficult exposures in trauma, reflecting all the abdominal contents to get to the retroperitoneum, etc., so that our residents are really well prepared when they get on the clinical service. And here's just a listing of some of the things that we do in this fresh tissue dissection lab. So in summary then, acute care surgery in the United States evolved from a system of trauma care that has had a relatively short but illustrious history, extending, as I mentioned, from the frontier days up to the current level 1 trauma centers. But this golden era of trauma management is really gone. Non-operative management is on the increase. Well-trained emergency medicine physicians are challenging the surgeon's role as the king in the trauma environment. And the traditional model, at least in the United States, really doesn't work anymore. General surgeons are becoming specialists. They're not interested in emergency surgery. And for all of these reasons, I think acute care surgery is really the solution. Thank you very much.
Thank you very much, Professor Hagen. So could I summarize in Japanese? 少し日本語で説明をしたいと思いますけども、南カリフォルニア大学というのはロサンゼルスのダウンタウンにある大きな病院大学病院なんですけどですね、大学病院の隣にカウンティホスピタルという、これはなんていうか市民病院みたいなのがあるんですけども、大学病院のドクターは大学病院とカウンティホスピタル両方で働いています。両方で。でカウンティホスピタルというのは基本的に保険を持ってない貧しい人たちが来るような病院で、そこにさっきあったような重曹とかですね、そういう思想とかいろんなトラウマの外傷の患者とか緊急手術を要するような患者さんとかいっぱい来るわけですけども、そこにですねカウンティホスピタルに全米で一番大きいというエマージェンシールームがあります。で、そこのエマージェンシールームは109のベッドがあるということですね。で、大きさが3ブロックと言いましたけど、3ブロックという1ブロックというのはちょっと建物と建物の間ぐらいで80メーターぐらいですね。だから3ブロックスといったら240メーターぐらいの大きさの建物があって、年間20万人ぐらいの患者さんが来るということです。すごい、全米で一番大きいエマージェンシールームだと思いますけど、それでアメリカでですね外傷の外科というのが非常に進んだ背景にはですね、やはり戦争があるということを言われました。で昔からですねヒポクラテスはいいサージャンにいい外科医になりたければ戦争に行けというふうに言ったということですね。戦争とともに外傷の外科というのが進んできた。例えば第一次世界大戦で初めて輸血というのがなされたということですね。それからレントゲンというのも取られるようになったと。それから第二次世界大戦でペニシリンが使われるようになって、それからヘリコプターの搬送というのが始まったというようなことを言われています。しかしアメリカもですねだんだん外科医不足になってきてですね、逆にエマージェンシーメディスンのドクターは増えてるけど外科の人はどんどん減っているということで、そのトラウマサージェリーということだけでですねチームを人員を維持するというのが非常に難しくなって、2005年ぐらいからアキュートケアサージェリーと今日のタイトルですけど、そういう新しい分野ができてきたということです。これアキュートケアサージェリーというのは外傷だけじゃなくてですね まあ、一般外科が受け持つ緊急手術の分野を全部受け持つと。例えば虫垂炎であり急性胆の炎でありイレウスでありヘルニアとかですね、そういう緊急手術の部分と外傷と両方受け持つと、まあ、そういう新しいスペシャリティができて、そして大学病院の教室として2007年からできるようになったということです。で、USC では1991年に南アフリカのヨハネスバーグからその外傷の教授が来られたということですね。現在は4つのチームで24時間カバーをしているということです。非常に多くのアキュートケアサージェリーのスタッフドクター、それからPA と彼が言いましたけど、PA というのはフィジシャンアシスタントということで、これ日本にないんですけど、まあ福井市とでも言うんですかね、医師の免許は持ってないけども、医師と同じように例えば脱臼の制服をしたりとか縫合をしたりする職種の人がいます。それからプラクティショナルナースというのも言ってましたけど、これは日本でいうところの特定看護師になるんだと思うんですけど、So could you explain the difference of practitioner nurse and PA?
Yes.
They do surgery both?
No. In nurse practitioners usually work in the clinic and in the hospital ward, helping with just the day-to-day activities there. They will do some procedures, mostly things like removing chest tubes or drains and things like that, wound care, but they don't participate actively in the operating room. Physician assistants, PAs, do some of the ward work as well, but they go to the operating room and assist there. So they have slightly different training and different backgrounds.
PA work in the operating room?
Yes.
Oh, okay.
They work in the operating room and with us on the wards.
Mm-hmm.
And the nurse practitioners work on the wards and in the clinic, but not in the operating room.
Okay. ちょっと私もプラクティショナーナースとPA の業務分担が分からなかったので今ちょっと聞いたんですけども、プラクティショナーナースはですね、今聞いたところによるとドレーンを抜臼したりとかですね、例えばチェストチューブというのは胸腔ドレーンですね、そういうのを抜いたりとか、傷のガーゼ交換とかですね、傷の処置とかそういうのをするということですね。で、ナースプラクティショナーが手術室に入るということはまずないということです。それからPA というのはフィジシャンアシスタントという、福井師とでもいうポジションの人ですけど、彼らはやはり手術室に入って手術の助手をしたりとか、あるいは病棟でですね、いろんな縫合をしたりとかそういう仕事をすると。So mostly PA is a male.
Yes, most commonly they're male, and most nurse practitioners are female.
Female. ナースプラクティショナーというのはほとんど女性で、PA はほとんど男性だということです。で、アキュートケアサージェリーのタイムシフトの時にですね、それレジデントとかスタッフサージャン以外にもプラクティショナーナースとかPA と一緒にカンファレンスをするということです。それからあと USC の非常に素晴らしい業績というのをいろいろ発表してもらいましたけど、いわゆる重装ですね、重装で手術をしなくてもいいんだというような のをCT で読影してですね、そしてこういうのはしなくていいというのをどんどん発表されてきて、有名なアーカイブ・オブ・サージャリーとかアナリス・オブ・サージャリーというので発表されたりとか、2001年はその重曹とか疾走の 42% 手術をしていたけども、2012年から 26% に減ったと。ほとんど手術をしなくてもマネジメントできる。先ほどありましたように肝損傷とかですね、非損傷とか腎臓とひどいやつでも手術なしに救命できたという話がありました。以上なあれですけど、泉先生、ちょっと見てきた感想を今日泉君が来てますんで、去年USC に行って1ヶ月ぐらいですかね、はい、実際病院で見てきてますが、ちょっと印象とか感想を言ってもらっていいですか。
熊本大学の消化器外科の泉と申します。昨年までこちらで2年間働かせていただいてまして、国立病院機構の短期留学制度を使わせていただいて、ロサンゼルスのベテランズホスピタルというところに2ヶ月間行かせていただいたんですけど、その中で結構フレキシブルなプログラムで自分でいろんなところに行っていいっていうふうなことだったので、ちょうどヘーゲン先生に一度こちらでお会いしてたので、メールしてちょっと見学に行かせてくださいということで、2週間だけなんですけど USC の方に行ってきました。で、先ほどあったように大学病院とカウンティホスピタルという軍立病院、いわゆる市中の病院なんですけど一緒に並んでいて、主に、USC の大学病院の方に大体10日近くいたんですけど、そちらも今日全然話出なかったですけど、食道外科の非常に全米でも有名なところで、まずロボットサージェリーとかもやってて、いろんな見学者がいっぱい集まるような大学病院なんですけど、そちらで見学をした後に、今日話があったカウンティホスピタルで、2、3日、4日ぐらいですね、見学をしました。で、そちらは本当にすごい大きなトラウマセンターで、サッカー場ぐらいの、サッカーグラウンドぐらいの ER があって、4つぐらいに分かれてて、先ほど言った109個のベッドがあって、もうずっと救急車が入ってくるようなところで、やっぱり一番すごいのは何かなと思ったところが、数が多いからどんどんシステマティックになっていってるんだと思うんですけど、もう外傷トラウマティームしか使えないようなエレベーターがあって、それがオペ室のもうすぐ裏につながってて、来て 2,3 分ですぐオペ室に上がったりとかができるとか、あとそのエレベーターがそのままヘリポートにもつながってて、ヘリポートからもうそのままオペ室に入ったりするようなこともあるような、すごくシステマティックな建物自体が作りになっているというようなシステムで、実際にそちらに見学に行かせていただいた時にフェローの人とかレジデントの人に、ぜひ週末の夜にも来て遊びに来たらいいよみたいな感じで言われたので、土曜日の夜に行ってきたんですけど、早速行って1時間ぐらいで外傷じゃなかった銃の撃ち合いがあって、3人ぐらいの銃で撃たれた人が一気に運ばれてきて、そのうち2人は5分ぐらい手術室に入るというふうなのを経験させてもらって、すごいエキサイティングな体験をさせてもらいました。実際に話があったように、夜は2チームがカバーをしていて、1人のスタッフと4人のレジデントでやってて、たったそれだけで同時に3つとか4つとか行われるような手術を入れ替わり立ち替えこなしていっているというふうなところで、本当に短い間ではあったんですけども、すごく楽しい経験というか、日本ではなかなかできないような経験をさせていただきました。
はい、So he explained what he saw in the hospital, and he said he's very impressed about the elevator from the emergency room to the operating room and the helicopter all to the operating room. Very systematic care was done, he said. それからもう一つヘーゲン先生が言われた フレッシュティッシュダイセクションというのを言われたのはある意味分かられたでしょうか。これちょっと日本じゃ絶対ありえないんですけども、不法移民の人がすごくいてですね、身元不明のその銃で撃たれた死体とかがいっぱい来るわけなんですよね。でコーナーという彼が言ったのは検視官のことですね。法医の検視官の人が結局そういった身元不明の遺体を冷蔵庫に入れといて、そしてそのレジデントがですね解剖をしてそのこういうアキュートケアサージャリーのトレーニングをするというのをこのフレッシュティッシュダイセクション、年間80例ぐらいやってるということですね。日本じゃちょっと考えられないんですけどね。大体死相が年間1100例ぐらいあると、そのうちの大体半分以上は重曹ということですからですね。平均で1日2例ぐらい重曹が来るという、そういう非常に特殊な環境で、見ていてすごい設備で、アメリカすごいなと思われたと思いますけど、アメリカの大学でこんな素晴らしい設備を全部揃えてるかというとそうじゃ決してありません。USC が一番設備がですね、外科のプログラムも一番優れていて、外科のレジデントが一番応募が多い大学はUSC ということでですね、大体6人のレジデントの枠に800人ぐらい応募が全米とかカナダから来るという、そういう病院ですから、全部がこうだというわけではないというのは理解しておいてもいいと思います。So there are 6 seats for the surgical residency per year. Seven. And you told me 800 candidate come
Yes.
application. 800.
Yes.
今定数は7なんそうですけど、やはり800人ぐらい応募が来ると、非常に教育システムがですね、外科の教育システムが優れている病院です。何か質問とかないでしょうか。日本語でも結構ですね。はい、どうぞ。
Picture. I am training to be acute care surgeon, especially for trauma surgeon. But in Japan, we have just few hospitals to have a acute care surgery unit and the program to train. So if you are in Japan, from what would you start to make a unit or training program? What do you think?
Yeah. Well, that's a good question, and you really need to have support of the hospital and the general surgeons that work at the hospital in order to make it work. Because if you get into a situation where the general surgeons feel that you are competing with them, then it's not going to work very well. The reason it's worked out so well in the United States is because nobody really wanted to do that work anyway. So it was pretty easy for acute care surgery to come in. And so it really would depend on the environment at the hospital and the willingness of the surgeons that work there to embrace the idea.
山口先生が日本でアキュートケアサージェリーをスタートするにはどうしたらいいかというようなことを聞かれたんですけども、やはり非常に多くの病院がですね、やっぱりサポートしてしっかり環境を整えることが重要ではないかということですね。ア あまり負担にならないようにですね、十分無理がしないようにそういうのを整えていくということが大事ではないかと思って、非常に難しい現実があると思います。何か他にご質問がありましたか。はい、どうぞ。
Thank you very much, Dr. Hagen, Professor Hagen, for your amazing lecture. I wonder how many fields of surgeon you are attending, because today I heard about emergency surgeon, completely different from robot surgeon as I had last year. So I'm surprised to hear your lecture. And thank you very much. I have two questions. First, about the retention of gaze. Do you know? The gaze is the fabric. Do you know gaze?
Oh,
Gauze.
Gauze.
Sorry,
Yes.
gauze.
Yes.
Recently, our hospitals decided a rule to take X-ray just after finishing every surgery and make sure there is no retention of gauze.
Yes.
Because these days lawsuits are very problematic. But some doctors say that we have to make informed consent in advance, because some patients might refuse to take X-ray because they got radiation.
Right.
So, is it a matter of course in the US now?
That depends on the hospital. At USC, about 5 years ago, we had 3 cases of retained gauze in 1 year. And so you can imagine that our lawyers and our insurance company were nervous because it's a big malpractice issue. So we looked at a number of different options. One of them was to do an X-ray at the end of every case. But we decided instead there is a system that's available. It probably costs a little more money than taking an X-ray, but each of the gauze sponges has an RF chip in the sponge.
Oh, really?
And so at the end of the case, there's a wand that a big wand radio frequency detector that you wave over the patient to make sure that nothing was left in the patient. And so that system has worked very well for us. It probably costs, for an average case, about $50, maybe $75 additional. But the hospital decided it was worth that money to prevent the potential injury to patients and lawsuits that go along with it. But I know many other hospitals in the United States that do X-rays at the end of the case. There's a number of very prominent. The Mayo Clinic does an X-ray at the end of every operation, and there are others.
Oh, I got it. Thank you very much. And may I ask one more question about anesthesiologists?
Mm-hmm.
Our hospital is an emergency hospital, and I think there is not so many surgeons here, but they are willing to do operation. But the most lacking doctor is anesthesiologist. So, who did anesthesiology in the US? Only the special anesthesiologist? And if so, are there enough anesthesiologist doctors in the US?
Yes. Yeah, the anesthesiology is a separate specialty. It takes 4 years, 1 year internship, and then 3 years of residency to become an anesthesiologist. It's a very competitive residency. Lots of medical students want to become anesthesiologists. And about 10 years ago, they actually thought we had too many in the United States. But now it's about right, number-wise.
So it is completely different from Japan. In Japan, I think the anesthesiologists are lacking. Is there any good way to seduce young doctors to become anesthesiologists in Japan?
Is there any way to encourage it? I don't know. In the United States, the reason that it's so popular is two things. Their work hours are not as severe as surgeons, so they don't work, they work regular scheduled shifts, so they don't have all of the emergencies they have to come to the hospital for, and they get paid a lot of money. So in the United States, that's how they get plenty of anesthesiologists, because they're paid well and good lifestyle.
I see. Thank you very much.
I don't think that probably helps in Japan, but that's,
We don't have a doctor fee.
right.
Only hospital pays the salary to the doctor. 最初の質問がですね、先生の質問はガーゼの置き忘れですねのことで、うちの病院全部レントゲンを取っているという話で、アメリカではそれをどうやってるかということですけど、ほとんどの病院はやはりレントゲンを取っているということで、名誉クリニックなんかもレントゲンを取っているということですけど、USC は特殊なガーゼですね、radioactive ガーゼ、
Radio frequency,
Frequency.
RFID.
RFID なんか外貨カウンターみたいなのでピピピピピってガーゼがあったらディテクトできるような特殊なガーゼ、なんかすごく高くて1手術あたり$50とか$70ぐらいコストが高くなるそうなんですけど、レントゲンを取れるんですね。それを使ってそっちの方がうまくいっているということでした。それから2つ目の質問が麻酔科が日本は不足しているけどアメリカはどうかという話でしたけど、アメリカは非常に麻酔科は多いということですね。その理由はタイムシフトがしっかりしていて、外科なんかに比べると非常に仕事勤務時間が短いというのと、それからサラリーがいいという話が出ましたけど、アメリカは病院がドクターに給料を支払うのと別にですね、例えば手術とか麻酔とかいろんなそういう仕事をすると保険会社が直接ドクターにお金を払うドクターフィーというのがありますからですね、そういうドクターフィーが非常にいいという、そういうあれです。他に何かご質問ないでしょうか。Okay, I think everybody has really satisfied. Thank you very much. So please give him a good round of applause. Thank you.